Hello, I'm Rajiv Jauhar. I'm the Chief of Cardiology at North Shore University Hospital. My talk today will be on lessons learned from the COVID pandemic, a paradigm shift in cardiac care, and the use of the Cobra stent in different cardiac situations. I have no disclosures. In early March, when the COVID-19 pandemic hit New York, and we were the epicenter, probably in the world, with our own health system having over 15,000 patients with COVID, the country shut down. The new norm became our recovery space becoming a COVID unit, our auditorium becoming a COVID unit, our cardiac short stay unit becoming a COVID unit, having a mobile hospital up the hill in a parking lot for COVID patients, and using an old cath lab to recover the few cardiac patients that did come to the hospital. We learned a lot from COVID-19. We also learned that there were a lot of cardiovascular manifestations, including hypercoagulable states with PE and stroke, especially in young people, and late presentation of acute myocardial infarctions, because COVID-19 did not treat cardiac disease, but yet patients came in to the hospital late. This lady, for example, presented only after she could not breathe. And we saw a lot of patients like this who had Q waves on EKG, very high BNP and troponin levels. And really, she had a closed LAD in cardiogenic shock with an echo that showed a dyskinetic apical wall and another echo that showed thrombus in the LV apex requiring Coumadin therapy. We saw a lot of patients with hypercoagulable states. This gentleman presented after COVID with bilateral PEs that with thrombectomy and the use of DOACs led to him being discharged home. We realized very quickly that blood thinners may help patients with severe COVID-19. And that led to the assessment of whether patients who are on these therapies and develop cardiac disease, what would be the best therapy? Well, we were part of the Cobra Reduce study using the Cobra stent. And so here's a situation of a patient who did not have COVID, but is a 70-year-old gentleman with atrial fibrillation on Eliquis, diabetes, who presented with chest pain, had a CT angio which showed severe mid-LAD and moderate right coronary artery disease, was on Eliquis, diltiazem, and metformin, and showed really a non-obstructive circumflex lesion, but a significant mid-LAD lesion, which with IFR was significantly positive, with FFR, sorry, was significantly positive. Patient got stented with the Cobra stent and did very well and was discharged home. These are the situations we can extrapolate into the COVID era with patients who have COVID on a DOAC or vitamin K and require intracoronary stenting. In this situation, the Cobra stent may actually provide the short DAP therapy that is necessary to decrease the risk of bleeding. COVID has not gone away, but we do see some glimmer of hope. Our recovery space that was a COVID unit is now back to us for cardiac cath. We are now seeing a resurgence of cardiac patients, non-COVID cardiac patients, but also COVID cardiac patients who are on DOACs, Coumadin, and other medications, coming in with unstable angina or stable angina with positive stress test, in which I think we can find a use for stents that require minimal DAPT therapy. I thank you for your time.